Good morning, everyone. It's great to be here. It's been a wonderful 2 days so far. I do have an acknowledgement slide at the end, but I just want to say from the beginning, I'm really grateful for our QI team. Joe had the award for helping with peds and adults, and Drusha's super helpful with all this data. So I'm very appreciative of them. Um, Working on advancing here. Oop, not that one. So there we go. Got it. Okay, we're good. Up, down, good. Okay. This is a recap of what our program has done in the past few years. And so I'm going to try to be efficient because we have lots of really other interesting speakers and topics that are going to be presented today. So we want to make sure we have time to get to all of that. Our program is designed to support individuals who may be at high risk for diabetic ketoacidosis. And so we've identified people by looking at recent admissions to the hospital or who have an A1C that is 9% or above. If anyone was able to be at the remote monitoring diabetes data session yesterday, a lot of cool things that we could add into this based on that information. So I look forward to hopefully incorporating that. Our goal is to decrease admissions, improve, A1C, and most importantly, the quality of life for the people in the program. So, again, at prior sessions, we've gone over this in more detail, but these are the different items that we're looking at that might be contributing to some of the issues. And Again, there's nothing new or surprising on here, but even though we're in a state that is actually pretty well supported with transportation and Medicaid cabs and stuff like that, that still is a pretty huge barrier. So just working with all of these things to help out our patients. This was our initial curriculum. It's just presented here. It was a little bit more regimented. We had the first visit and we had what we were going to go through for that visit. We had the next visit and that was planned out. In our subsequent iterations, we've been a little bit more flexible with what the different patients have wanted to talk about and what they may need more specific help with. Some of the changes for our most recent cohorts, and it's now kind of a rolling admission program, whereas initially it was a fixed number of people while we made sure we had enough resources to help everyone. But we added some more visits, so there was a little bit more flexibility to focus on what each individual needed. And we were very fortunate to have a psychologist added to our team. That's been a really wonderful addition to the program. And she'll meet with the participants if they want to over a short term and then try to connect them with someone more local because we have a decently large catchment area and it's not always feasible for them to come long term. Of course, the social worker is extremely helpful as well. And we had a pretty strict kind of return to usual care, meaning no longer involved in the program if there was a certain number of missed visits and or other factors, cancels, no shows, which we eliminated for this cohort, these two. This is a 2024 cohort. It leaned a little bit more female than male, and again, there's a little bit more with public insurance rather than private. You can see kind of the A1C changes at the bottom there between the two groups. On the far right, the people that did not complete the whole program didn't have much of a change in their A1C. And on the left, again, there was at least some change in the mean A1C. This graph is showing what the different individuals' A1Cs were at the start of the program, when they completed the program, and then 6 months after. The one that's missing finished. We don't have the 6 month data yet for that person. That's why it's missing. But in general, you can see there's generally some improvement for everyone, even if there's maybe a little bit of higher numbers part through. I think something in the program stuck and helped out the individuals later on. So our 2025 cohort is a little bit flipped, and there tends to be more male participants in this group than the prior group, still with more public insurance, and we don't have the follow-up quite yet. One thing on our next slide that you'll see, I think, is important to think about kind of the individuals, because what will stick out in the 2025 cohort is that when we're looking at the DKA events, um, one of our individuals had 24 out of the 35 for the whole group, obviously not what anyone wants. And that individual is uh, doing better, but in our data, they're going to be still having some episodes of DKA, but throughout the year, instead of coming in obtunded or very tired and not responsive, the individual is recognizing things sooner, getting to the ED sooner, has actually come in twice now and not been in DK at all. So even though some of these things may not show up in kind of the broader data set, I think the program has helped him quite a lot. And just again focusing on him, there's some barriers there with insurance and pumps, and he won't want to check and those sort of things. And so the insurance won't start the pump. So we're just working really closely with him, and hopefully it'll just help him have a better life. So next steps, again, we need to finish out this cohort and see what changes we need. One of the things I'm looking forward to doing is adding a questionnaire for the individuals to see what actually helped them the most. I think sometimes we might like to think it's all our education and stuff, but I have a feeling it's being connected with the educators who are communicating with them, making them feel like they have someone who really cares about them outside of their immediate support group. And so we'll see if that is an accurate thought or not. But I think that's been a huge help, and our educators have been really amazing with this. And again, coming up with other changes based on that feedback. So these are all the people involved, highlighting especially the educators, psychologist, our social worker, child life dietitian, and then our QI team I mentioned, and then our management that lets us do all these things. So that's what I have for now, and I'm open to any questions.
All right, thank you so much. And finishing up before time. Any questions? And I can probably start with that. So that one individual, 24 admission,
Yes.
what's going on here?
So I know our clinic sees people through 21, and so he is an adult, and a lot of times we'll be able to get some extra services involved, and we haven't in that case. He has some mental health concerns as well, and very little support at home. So he's trying to bridge the gap, live on his own, and he knows what to do, but if depression or anxiety comes too much, kind of falls into some prior habits that aren't helping him stay out of DKA.
Yeah, and the reason why I asked that, I think, in Colorado when I was there, I think we did a lot of research on marijuana and type 1 diabetes. And what we realize is that those recurrent DKAs are not really due to diabetes. It's because of cannabinoid hyperemesis syndrome.
Mm-hmm.
And I was just very curious that is that something? And then most people, at least in our studies, were using cannabis for anxiety, depression, and some of the reasons for their mental issues. And so I was just curious to see is that something happening here? It's really related to diabetes, but
yeah, we have been able to transition to more prescription pharmaceuticals to help with some of those concerns. So hopefully, I agree that will be good for the future.